Good afternoon, everyone. So we're gonna really keep it short and succinct, and we'll be really very clinical, because I know these conferences are actually primarily made for junior doctors to learn something out of it. So I'm just gonna keep it very simple and clinically oriented. So first of all, I'd like to introduce our panelists from right to left. Dr. Kadir Orhan from Turkey, and my friend Dr. Sampath Prasad Rao from Bangalore, India, and my very close friend Dr. Magid Bahir from Suez Canal and military, and Professor Stankovic from Serbia. So the objective of this panel discussion is to really present some clinical scenario that I have dealt with almost 90% of these cases actually in my university hospital, Al Hussein University Hospital. And the whole idea is to really bring up to the discussion of how the decision had been made when we are confronted with these cases. And that obviously would have a bearing on the benefit to the junior doctors in this room.
Ali, excuse me a little bit. We don't have a synchronized screen here. We cannot follow you.
Right, okay.
No, we have to synchronize the screen.
So is it not synchronized now? So I am on this objective, right? Okay.
Netflix.
So
Have to move it.
is it synchronized? I am on the clinical scenario 1, is it? Yeah, is it okay? Right, okay. So this is a 55 years old lady who actually presented to us with a persistent right ear discharge and hearing loss for a few years. And that is her clinical examination. That's actually endoscopic examination. And it shows, as you can see, it's a central perforation. And you could see the moisture of that. It's been just clean, really. And you can see just these blood droplets coming of this kind of cleaning of this ear. So it's a center perforation, doesn't want to dry up in a 55 years old lady. And you could see the hearing test showing this right conductive hearing loss. And that is some sections of her CT scan. As you can see, the CT scan there showing erosion of the outer cortical part of the mastoid, but also erosion of the tegmen tympani and tegmen antri as well. And not only that, but it actually shows what I'd like to call it moth-eaten appearance of the rest of the air cells. And you could see no posterior fossa bony separation, and it's just on the dura straight away. And And that's one of the areas where you look at the report, and some surgeons follow the radiological report. And the report, as you could see there, is suggestive of cholesteatoma. Someone coming with a central perforation, persistent discharge, and then based on this erosive behavior of the pathology, the radiologists usually label this as cholesteatoma. But then we actually asked for MRI scan, and this MRI scan, as you could see there, there's actually the one on the left-hand side, top left. This is actually a T1 weighted MRI scan, and you could see the pathology kind of, shining there. And the same applies, but that's actually flare sequence where both the fluid and fat can appear whitish. And the same applies to these. And the report, as you could see, it has been reported as showing being kind of erosive pathology in a vascular lesion. So we saw this patient, and then the decision what to do. So my question to Dr. Kadir, any explanation for this paradox of having a central perforation whilst the pathology is kind of erosive, has been reported as cholesteatoma as well. So can we reconcile cholesteatoma with a central perforation? ما تساعدونا بقى يا شباب، ساعدونا. بشوف يلا الحجارة خلصت. ما فيش عندكم حجارة بالسبير؟ حجارة.
Yeah. Is it? Yes.
Yes, okay.
So there's a central perforation of the eardrum. Actually, we don't expect the acquired cholesteatoma in these cases because. I hope سمعت.
Yes. ما تساعدونا يا شباب.
Oh, تعال.
Perforation. Escape. But it's in the middle ear. But defect, but it is the but
Right. So the first lesson to the juniors is actually when you have the radiologist reporting that this is actually cholesteatoma, and then you have a central perforation, try to question this. I think that's what Dr. Kadir has actually pointed out is you have to question because it is usually the case that cholesteatoma would lead to marginal perforation rather than a central perforation. So that is the first educational lesson. Sampath, you have had this patient coming to you, you've done the CT scan, audiometry, MRI scan. How are you going to manage this patient?
So I would get a DWI MRI in this particular case, non-API sequence to rule out cholestoma. So it's routinely done during the MRI sequences themselves. So that will rule out cholestoma. So in this particular case, there is clearly a tegment defect, and there is a extravasation, and there is fluid, and its fluid is hyper intense on T2. So this is a fluid collection. This is not a cholestoma, and there's an extensive fluid collection. So this, as Professor rightly said, would lead my mind towards meningoencephalic herniation. And in such a case, I would go use a middle fossa approach, provided that I have ruled out cholestoma because if
Well, the diffusion weighted MRI scan showed no restriction.
restriction,
And that is
excellent,
actually reported in this report. I didn't want to waste time, but it was reported as showing no restriction.
excellent.
So very unlikely to be
Of course,
cholesteatoma.
of
So
course.
your approach is
Then in that case, if the hearing, there is like a mixed hearing loss, I would like to preserve the
there's
hearing.
actually it's more of a conductive, right?
Yes, conductive,
Yeah.
yes. So I would probably go in for a middle force approach to seal the tegment defect. And then once the CSF is controlled and once the meningoencephalic
Well,
herniation.
because there is no CSF, by the way.
So what was the cystic component?
CSF would not show white on T1, as you know, because T1 has shown signals
Yes.
in actually in T1, T2, and flare sequence has shown signals
Yes.
as like bright pathological lesion.
In fact, that is why I asked them to remove there was something obstructing the T1 sequence. So CSF. So now
Sampath, you can see it now.
So T1, it's hyperintense on T1. It's hyperintense on T2 as well.
Yes, that's
It's
correct.
hyperintense on T1 and T2.
And no restriction on diffusion weighted.
So the only two things which are both hyperintense on T1 and T2 are petrous apex cholesterol granulomas or cholesterol granulomas and fat. Both are hyperintense on T1 and T2.
And that's exactly what I thought, what we thought as a team is actually, this is going to be cholesterol granuloma most likely because of this unique features on MRI scan.
Yes.
And that's why we went ahead actually with the classic post-auricular approach as you can see now. So that is what we did.
Ali, this is a case of erosive skull-based pathology where the radiological characteristics were almost orthogonal of the pathology.
So I'm harvesting this temporalis fascia graft, right?
Where a post-auricular incision was undertaken and temporalis fascia graft was harvested. Now, the pelvic flaps
Can you see this?
elevated.
So this is exactly a blackish, tarish fluid coming out.
Discharge, pulsating discharge,
And it was pulsating because the dura is exposed.
mastoid.
So that was a defect.
Innovation is now completed, and as you can see, there is a defect in the mastoid cortex.
I was trying to harvest this cortical bone so that I would reconstruct the defect later on.
I am now trying to harvest a piece of cortical bone to be used later on for reconstruction of the skull-based defect. Now, this is the mastoid cortex being removed.
By the way, this whitish structure is actually the endolymphatic sac.
Completely exposed.
This is the endolymphatic sac there.
You're right. And that's in the middle cranial fossa neuron. I am now trying to remove the air cells which were filled with the pathology.
This is what was sent for histopathology.
Taking me to the mastoid entrance. And this is the pathology being removed and sent for histopathology. That is the mastoid entrance.
Just for the sake of time,
Mind you, this patient had central tympanic membrane perforation, which I have grafted using temporal fascia grafts.
So this is the jugular bulb in front there.
Posterior fossa dura. And the white structure that you can see in the middle there, this one is actually the endolymphatic sac.
The pathology has created this.
Structure in front is actually, this is the jugular bulb there.
I am refreshing the edge of the perforation now, and I did just tympanoplasty.
The edge of the...
But for the sake of time, I just need to gonna skip this. Now, what I did, Professor Beheiry, is that I used a bone wax and I separated the mastoid antrum or aditus ad antrum. I plugged it with a bone wax so that I would separate the middle ear cavity from the mastoid cavity. And I have not reconstructed the tegmen nor the posterior fossa bony plate. Now the question is, and I did tympanoplasty, just ordinary tympanoplasty. The question is, would you have dealt with it differently? Would you have separated the aditus ad antrum from the mastoid ball?
First, I wanted in the first place to have a CT scan, not an MRI. MRI will help, but the CT scan is very vital for you. First, it will show you the air cell tract of the or pneumatization of the ear that you are going to approach. So you know your tracks, so you know where the things are and which tract you are going to follow. If you are going to have to,
we did CT scan and MRI scan. I showed you initially.
I don't recall. No, you did not. You only show us two cuts, which were not sufficient.
Just for the sake of panel discussion, but obviously we did.
Okay, but separating the aditus from the mastoid ball, I don't think this is. I mean, it's not going to help. Why are you doing that? Because you have a clean cavity behind the pathology.
Let me pose this question to Prof. Stankovic.
Okay.
Well, it's very difficult to give a definite answer. If you're sure that you have cleaned all the cells and all the pathology, you don't have to, and if you're sure that there will be no recurrence of the problem,
right?
You shouldn't. I mean, you get nothing by.
Well, I'll tell you why I thought this, because I thought the eustachian tube is open from there.
Yeah.
And I don't want any infection to come to this. Really, dura was very flimsy, by the way, this posterior fossa, although I kept it intact. But I thought, like, extra cautious to actually separate the middle ear from the. It's a huge cavity, by the way. It was actually reaching anteriorly to the jugular bulb, kind of infralabyrinthine approach, as you do, we do. So
when you have an aerated cavity, you don't have to worry about. Okay, and mind you that bone wax is not natural. It can invite infection. Okay, so if you are worried about infection, you are inviting infection. The mastoid cavity is clean. If you have pneumatizer cells, that will take care of the.
No, it's the dura. There's no bone at all. It's actually the dura being exposed.
No problem. In skull-base surgery, you just open the thing. Openly wide. And you don't fear any infection because
right. But Sampath, would you or Kadir, anyone would have dealt with it differently?
For me, this would either be a middle fossa reconstruction or a subtotal petrosectomy. I would do a blind sac.
Why?
I would because the dura is exposed. And when the dura is exposed, there is always, it's like a ticking time bomb. There's always a chance of meningitis if the cavity is not secluded from the environment. So the dura needs to be protected either by a graft, like a big cartilage, you put a temporalis fascia, make it a 3-layer. That is, if the defect is less than, let's say I would go up to even 3 centimeter, But if it's greater than 3 centimeter middle fossa, then it's a blind sac.
Sampath, you see, the whole middle fossa, the
Is
whole posterior
completely-
fossa dura was exposed. There was no way that you can actually reconstruct it. There
Then
was
it's
no
a blind
way.
sac. Then it's a blind sac for
Well,
me.
why blind sac?
Because I feel that I mean it could hold today. The tympanoplasty might hold. The bone wax will eventually lead to granulation. Bone wax leads to granulation. So bone wax won't hold. So I personally feel that the dura is at risk long term. I'm talking about 2 years, 5 years,
Right.
10 years later. And if there's any amount of infection coming through the stitching tube or through the external ear canal, then so much of dura being exposed is a threat to the patient lifelong.
Right. So now the subsequent question to this is the histopathology confirming as we anticipated, and that is the patient 2 weeks post-operatively. As you can see, the perforation that we saw initially is being sealed off.
It's actually, he said,
So the educational lesson here for youngsters is this makes a strong case for radiological investigation in mucosal type of chronic suppurative media, especially if the discharge was persistent. You know, these old arguments is that if you have a central perforation, you don't have to scan. But if it is persistently discharging, I think it is important to scan these patients. Cholesteatoma usually presents with marginal perforation rather than a central one. Clinical radiological correlation is indispensable. I think that is probably for the junior staff. Now, I'm going to take you to the second scenario. Is the another lady who's a 23-year-old lady who again came to us in Al Hussein University Hospital with a right oral polyp, right ear polyp, no discharge, no tinnitus, no vertigo, but every now and then like facial twitches. That's it, nothing more. And that is the polyp. As you can see, there is kind of very dry and a clean polyp, no discharge. That is the CT scan. Probably, is it clear in there? Yeah? Is it not clear? Okay.
Yeah.
So if we look at these cuts,
There's the point.
okay. Maybe I would point to it this way. Okay. So if we look at these cuts, we've studied these cuts well. You could see that there is actually a dumbbell-shaped pathology that is penetrating through the posterior bony meatal wall. And the rest of the air cells are actually clean. So there's no opacity, which means actually it's kind of a sterile pathology, if you like. Now, I made this a bit clearer because then you could see مع حضرتك يا دكتور أحمد؟ طب الليزر بوينتر ده ماشي okay. So if we look at this here you could see it jumps يا جماعة مش فاهم ليه. Okay, so you could see that this is the penetration of the posterior bone in the meatal wall. If you look at the coronal CT scan, one characteristic finding is that the stylomastoid framing is quite dilated. So enlarged stylomastoid framing, right? So that is the radiological finding for this. And we did MRI scan, and you could see that the MRI scan is almost homogeneous, enhancing, dumbbell-shaped pathological mass. So the question is, and that is the MRI scan. As you can see, I think it's clear now, the pathology going from the mastoid to the external auditory canal. And that is this lady's audiogram showing conductive hearing loss of moderate degree, not a lot, coming very smiley, very pretty, nice smile, coming to us with oral polyp and just a bit of conductive hearing loss. That's why she came. Then the question is, what do you think is it, Prof. Stankovic, given these clinical and radiological features?
Well, it was cholesteatoma as the first idea, but
It's a homogeneous enhancement on MRI scan
uh,
with no restricted diffusion, by the way.
mhm.
And it's a dumbbell shape penetrating through the posterior bony meatal wall. And the rest of air cells are actually quite clear. It's a very blackish kind of jet black.
Well,
So-
if it is homogeneous, looks like a tumor. It's a tumorous tissue, and I would treat it like a tumor.
Right. Okay. So most likely a tumor. Do you think, Professor Bahad, that this is benign or malignant, given these features?
I think it could be a facial nerve neuroma.
So it's a facial nerve
Benign
neuroma, yeah.
lesion.
Or facial nerve tumor, most
Yeah.
likely.
Yes.
Yeah. Sampath?
So it's definitely a facial nerve tumor.
Definitely. I like definitely because it's actually, these are characteristic
Yes,
features for it.
yes.
I don't
So-
think any other pathology would
Yes.
know this, but the facial nerve benign tumors. Now, the question which I'm going to ask Professor Kadir here is,
It is a very difficult question for facial schwannoma. Actually, we expected the polyp, and there is a cholesteatoma behind the polyp, but in the MRI section is very similar to facial nerve schwannoma. So in facial schwannoma, the treatment is dilemma because she has not the facial paralysis. If you remove the tumor, the facial, we have a facial paralysis. Actually, in my practice, I will do the mastoidectomy, canal wall'dan mastoidectomy in this case, and check the nerve integrity, monitoring all the section, all the area of the tumor. If it works in all the tumor, we have two options:
no,
resection.
but we know it is working because the patient has normal facial function.
Yes.
So I don't
yes.
need to open the mastoid to have the data that the facial nerve is functioning.
Yeah,
Because it is functioning.
In normally facial nerve schwannoma, we prefer to facial nerve decompression and wait and see. Or
So you're gonna
Re-
decompress the facial nerve
yes,
and leave the tumor?
yes. In facial schwannoma, yes,
but
I prefer.
mind you, Prof. Kadir, this is actually a 23 years old lady. She has a long life ahead of her. I think that should, well, in my view, would make a difference in terms of if this was I'm
in
not
my
talking about
in my
age.
practice, in my practice, I decompress the facial nerve and leave the tumor, follow the tumor. If we have a facial paralysis, and I remove the tumor and make a cable graft.
In a 23 years old lady.
Yes.
Right. Sampath, and I'll come to you. Sorry.
So here, the tumor is going past the stylomastoid foramen into the parotid tissue, if I'm not wrong. Now, there is one consideration.
It was actually standing on the verge of the parotid. It
The
did not-
stylomastoid foramen is fairly nicely widened.
Yes,
So
yes.
some part of it is coming towards into the parotid. It's definitely past the stylomastoid foramen. So if this is the case, there will be a point when we'll have to take a call apart from the normal facial nerve function, because if the tumor goes up to the bifurcation of the facial nerve, then we are looking at a 3-point junction in future where the results are very poor. So we'll have to use a split sural nerve graft. So that has to be taken into consideration and discussed with the patient. I agree it's a 23-year-old female, and there's a fairly intact facial nerve function. Hearing is good. But for me, the dilemma will be where I would look at the scans more closely to see if the tumor is reaching the bifurcation of the facial nerve.
So you're going to operate on her or not?
If the tumor is reaching the bifurcation, I would operate. But if the tumor is not reaching the bifurcation, then the choice is still hers. The choice is still hers. I would counsel. I would say you could wait. Wait and scan would be something I would push her for. But also here, the tumor is very close to the junction of the facial nerve.
So you would operate on her?
I would see the scans very closely. If it's coming closer to the bifurcation, I would probably lean towards surgery.
Because if you leave it,
Yeah.
it will come closer. She is at 23 years old.
Yes, so that's the reason. If it comes to
So,
the
so
bifurcation,
why would I wait until it comes closer to the bifurcation? It makes it bloody difficult for me to operate.
exactly. So in that case, this surgery right now would be the best choice. But then she has to take the call because she's a young
obviously,
lady.
yes. Patient
She's
choice.
a young lady.
Dr.
Yeah.
Prof. Bahir?
First, I want to make a remark. Facial nerve schwannomas do not appear very bright as such in an MRI. You know why it is bright? It's so bright because it's very close to the stylomastoid artery. So that gives the brightness to the schwannoma, which should not be as bright as such. Second thing, what do I do for this tumor? This reminds me of the first case of skull-based surgery I learned in 1989. It was about a facial nerve neuroma in the tympanic portion. And the dilemma and the argument was as such. If it were an elder girl, what would you do? I would leave it, okay? Or I would compress. If it is like this situation, a 23-year-old girl, I would definitely go for surgery with cable nerve grafting, which will lead eventually to not better than Hals-Brackman grade.
Yes. Okay.
Grade 3.
So I think the opinion is a bit. Professor Kadir is going to be very conservative and probably decompress the facial nerve. Professor Sampath will operate. I'm sure you will operate. I'm sure. I know. And Professor Bahir will operate, and Professor Stankovic would operate. Isn't it? Is a benign tumor in a young lady. Would you operate?
First, I agree with the thing that we should do wall down surgery. I would do it as a first instance. Then I will follow the oldest tumor. I will do the decompression around stylomastoid foramen. To be sure that the CT and MRI are adequate to what I will see with compression of the nerve, potential, let's say, mobilization or something.
Right. Okay.
Then I will finish this operation.
Right.
I will discuss with the patient in some days, and if it's there is no chance, and if there's a sign of progression, I would tell her that surgery is the best option in the month or 3 months. Or so.
Right. I
And if
think
she
the
refuses,
professors now, all of them are referring to the distinction between schwannoma and neuroma or fibroma, because schwannoma is actually originates from the neurolimmal sheath. So in theory, you can peel it off the facial nerve. But I have not actually come across this before. But anyway, but that is the theory behind it. I'll tell you what we did and why we did and the outcome. Yeah. So that we can go to the next case. So essentially, it was difficult for us to consent this lady coming, 20 years old, not married. In our culture, unmarried ladies, facial nerve is pivotal for marriage. And and then we really discussed with her the operation and the facial nerve, because if we were to operate, then this facial nerve would be from grade 1 to grade 6. We know that, as in short term, but then it will improve later on. So basically, we discussed this with the patient, and we thought of the rehabilitation measures, and this is what we did. Sorry? Yeah. No, we removed the whole thing. You will see, Dr. Ahmed. You will see it. It will come out. Yes. That's why we operate. Yeah. So essentially, it's the post-auricular approach. And I will show you actually that the tumor was actually encasing the whole nerve. There was no way you can peel the nerve off the tumor or the tumor off the nerve. This is the posterior limit of the tumor down there. So this is the posterior limit of the tumor. and I'm trying to get to the upper limit or anterosuperior limit of the tumor as well. So you can see the tumor in there. And the tumor is actually, as a, radiological penetration of the posterior bone in meatal wall. I have passed my, angled knife or Rosen angled knife through it. I have then encountered the malio-incudal joint, which I have actually separated. But that is the tumor. That's all of it is actually tumor there. I am separating the malio-incudal joint now. I could not reach to do incudostapedial joint because the tumor is covering the whole thing. So I've just separated this so that I would remove the incus and to avoid any inadvertent sensorineural hearing loss by touching it with the high-speed drill, basically. I think that's something that we all do when we operate on such cases.
The second genu?
Yes, it was actually from the first geniculate gang, just above the processus cochleariforms, down to the stylomastoid foramen. You will see the lower limit now, Sampath, you will see the lower limit of it, and is not reaching the bifurcation. I'll show you. Maybe I will forward this a bit. Can we forward the video? ممكن نقدمه شوية؟ من عندي ممكن أعمله من عندي؟ Okay, thank you. So essentially, I'm actually peeling the facial nerve off its fallopian canal now, and that is the tumor there. Yeah, that is the lower part of the tumor. You see, this is the lower part of the tumor, actually.
You are lucky you have a low jugular bulb, huh?
Wow, jugular bulb was not actually that. Wow, it was low. Yeah, you're right. You're right. Yes, absolutely.
You are lucky.
Yes, I am actually. I was. Yeah. So essentially, this is where the stylomastoid foramen was, and that's a piece of the tumor removed, obviously, for histopathology. It's quite a big tumor, by the way.
Tumor down the bulb. I see scan.
I just want to show you the bit of the facial nerve. That is the facial nerve. Just want to stop this. Can I stop it? Sorry. Oh, it's very difficult to mobilize it from my side. So essentially, I could see the lower limit. I cut the nerve, and I followed the tumor up to the geniculate ganglion. And then I used actually greater auricular nerve to reconstruct, as a cable graft, basically.
Yeah.
So that is kind of the epineural sheath of the tumor, and that is greater auricular nerve has been harvested. I know that Dr. Sampath liked the sural nerve more. I understand the your rationale behind it, but actually I found this much easier and closer to the vicinity where I operate. And
the greater auricular nerve is sometimes short, and you have to pull tension on the
you will see actually it was quite lengthy, Prof. Beheiry, and it was quite relaxed in the cavity. You will see it now.
other end, or if we should the proximal end, we have sutured the distal end
Can you see it, Dr. Magid?
till end. So the remaining end, the proximal end, which is going to be sutured by the greater occurred.
Anyway, just to for the sake of time, this is the lady post-operative, as you could see. I took her permission, by the way, this was post-operative. I think that was the second day. There was still some functioning muscle. If you do it, you know, the Wallerian degeneration versus whatever, but it's not complete palsy from the beginning. So essentially, that was the histopathology, as in schwannoma of the facial schwannoma, right? And that is this lady 11 months post-operatively.
أنا الأخت جهاد محمد اللي احنا عملنا لها الفيشل نيرف تيومر ريسيشن وعملنا كيبل درافت في فيروس انجريتر اوريكنا اذا بتحمل دلوقتي يا جهاد بقالنا قد ايه بقى؟ لا مش 11 دقيقة. طيب معلش يا جهاد استاذنك بس تحاول تقولي بين طيب.
She's closing her eye comfortably. I think she has some smile.
ابتسامة.
You can see the dimple on the right side.
How to
So I would kill this is grade 2, grade 3, sort of. Well,
شايف الحضارات؟
It's an excellent result. I think I agree that it's an excellent result. I'm a very skillful surgery.
oh wow!
Congratulations.
I'm not actually showing this to you, but actually for the youngsters to know how to manage and how to make decisions. Now, the lesson out of this case for me is like, not every oral polyp is a cholesteatoma. Please learn how to read CT scan and MRI scans. Don't rely on the radiological reports. With all due respect to the radiologist, but try to familiarize yourself with the classic presentation of cholesteatoma, because cholesteatoma has a classical presentation. If it does not fit into this classical presentation, then you really need to question that. Counseling was mandatory. I had to say to you, I spent quite a lot of time talking to this girl and explaining to her, because she was coming not from Cairo, which like urban city, was coming from rural areas, very close to, very west of Al-Fayoum, يعني, Al-Wahat. And their culture is completely different. And you see, probably their life is revolving around marriage and that kind of thing. So it was not easy decision to be made, but that is the outcome. The third clinical scenario was a 34 years old man this time, the previous were ladies. He came with a bilateral conductive hearing loss, worse on the right side, following right mastectomy undertaken 13 years ago. This man was from one of the governorates in Egypt, and he had mastectomy 13 years ago. And he came to me, to Al Hussein University Hospital, with this appearance. So that was actually was, you could see it without otoscope there. Yeah? So something like an egg for me. It was like, I thought this is a foreign body initially. But then he said, well, no, I had surgery and, you know, I cannot hear well. I did not put any egg in my ears. So basically, this is what you could see. And that is the other side, by the way. He had bilateral chronic suppurative otitis media, but then he came with this polyp, giving him this kind of mixed hearing loss, if you like. But it's actually bilateral mixed hearing loss. But also showing on the CT scan, you could see this tegment defect. And the pathology was actually contagious with the defect as well. And the defect on T2 MRI scan was quite shining, as you can see. So it's hyper intense on T2, right? And it was hypo intense on T1, by the way. And that is the audiological report of this man. So then the question, to Professor Sampath. You probably know the diagnosis. We know that this is actually a meningocele coming down the ear canal owing to the previous surgery that this man had undertaken. Now, the question is, would you approach it from above or would you approach it from lateral?
My guideline would be 2 centimeter defect. I'll be comfortable doing a 2 centimeter defect in the middle fossa. In the middle fossa floor, I would reconstruct it with a middle fossa approach.
Yes.
With the middle fossa approach.
So basically, the size of the defect would make Prof. Sampath choose which approach to undertake. Is that correct?
Yeah.
Yeah.
That's
تفضل
right.
دكتور. تفضل.
Yes, middle fossa mini craniectomy, and I would this meningocele is inactive. You can bipolar it and leave it in place. Okay, if to obliterate.
So,
it.
sorry, Dr. Magad, I didn't catch what you say. Sorry.
This is an inactive part of the brain.
Inactive.
Yes.
But it's a CSF.
Is there CSF leak?
It's a CSF.
Oh,
Well, it's
okay.
not leak. It's not leak. It's actually meningocele. It's a meningocele.
Yes, no problem.
It's not a meningoencephalocele. It's a meningocele.
Meningocele.
Yes.
Okay. So you can retract it using a bipolar. Okay. And
It was quite tense, by the way. It was tensistic, if you want to give you the
So you-
expression.
so you can put it back up.
No. It was tensistic.
So how are you going to close the defect?
I'll show you what I did. So Dr. Sampath said, depending on the size of the defect, I would choose the approach. Any difference, Professor Stankovic?
My middle fossa is going to be a small middle fossa, not the classic.
Right,
It's going
okay.
to be a small mini craniotomy.
So I know what you're going to do.
Yeah, that's the size of the defect is the decisive factor. Over 2.5 centimeters, it's advisable to do middle fossa.
So middle fossa, right.
Yeah, otherwise, it's nearly impossible to do it completely.
So middle fossa, yes. Okay, Dr. Kadir?
If there's a single defect, the defect size is very important. I agree with Professor Prada. So if greater than the 2 centimeter, I prefer the middle fossa.
Right.
If there are multiple defects, I always do the middle fossa in that cases.
Right. So I think that's very useful. So the size of the defect and the multiplicity of the defect would entice any surgeon to do it from above, because that is natural, isn't it? And I think that is what we did. So basically, this is what we did. It was extended middle fossa. It was actually middle fossa, but I had to go to the mastoid as well, because this patient had residual cholesteatoma deep to the meningocele, basically. So we approached this through the middle fossa as ENT, actually without the assistance of the neurosurgeon. So we lifted this craniotomy, and I actually took a bony flap out of this just to reconstruct the defect without having to go to the crista or the iliac crest, or just not to give the patient any more wound in the body. So basically, that is the. It was another small defect as well there. That was the primary defect. Actually, there was a stalk or a neck for the meningocele, which I have cauterized with bipolar diathermy. And I'm actually trying to get the graft now, the bony graft, so that I would kind of resurface the middle fossa, like a partial thickness bony graft.
Yes, was support the years. I can, they can result. But
This is
So that is the size of the defect, quite sizable. This is actually the arcuate eminence. This is the superior semicircular canal. This bluish structure there is almost blue lined. It's actually blue lined superior semicircular canal. So essentially, this is the bony plate that I have harvested of the craniotomy without going through the full thickness of the craniotomy, by the way, and then it was reconstructed. So that is the post-operative. You could see that is the bone that I have laid in there and closing the defect from there. The last scenario is this patient, who's a lady, 43 years old lady, with left ear discharge and deep-seated left ear ache, 3 years following left sterpidotomy, and she was generally well with no medical history of importance. So a lady had a sterpidotomy 3 years ago, and she is coming with this picture. This was from the health insurance المنيا يعني. And endoscopically you could see something whitish in the floor of ear canal. I thought this was Teflon piston initially, by the way. I thought this was the Teflon piston, and it was extruded as a result of the pathology inside. But then that is her audiometry showing mixed hearing loss on the left side and conductive loss on the right side. When we look at the scan, Dr. Sampath, any comments on the scan? Does it give you any clue as what the pathology was?
So, may I go back to the first slide of this case to just to understand what was the stapedectomy about? Left stapedectomy somewhere else. She was generally well.
Left.
So it's a 43. Is she a diabetic?
Sorry?
Is she a diabetic?
Sorry, I didn't catch.
Diabetic. Is she?
She is not diabetic.
She's a non-diabetic.
She is a very fit and healthy lady, by the way.
Okay.
Yeah.
So when there is ear pain, I look at two things. One is skull-base osteomyelitis or malignant otitis externa, and the second thing is malignancy. So there's a 43-year-old lady who's had a history of
But she
surgery
had a
elsewhere.
sterpidotomy on the same ear 3 years ago.
Yeah. So yes, can I go to the scans, please?
Right, okay.
Stepidot.
So do you want the scans, yeah?
Yeah,
Okay.
the scan.
Okay.
So
that's
there's granulation in the external ear canal. So this is showing mastoiditis on the left side. There is gross erosion around the area of the jugular bulb, petrous areas, and and there is bony erosion
yes.
all over the place.
Yes,
So-
it's actually like a bare hole in the mastoid cortex, as if someone has done a bare hole there.
Yes.
And this honeycomb appearance as well, which is was a bit weird actually. So what Professor Stankovic, what do you think the diagnosis is or was? Given the history of sterpidotomy on the left side 3 years ago, coming with
Yes.
oral polyp and ear discharge, and deep-seated pain was quite painful. But it's not the kind of pain that is persistent all the time. So it comes and goes. With this scan, anything in mind?
And she was quite well for the first 2 years, 2.5 years after surgery.
That is correct.
Yeah.
It's actually started 6 months, as in when I saw her, that was 2.5 years after
Yeah.
sterpidotomy.
So it has nothing to do with stapedectomy. Probably, some latent infection for such a period. It's quite unusual.
Right.
So we wouldn't expect osteomyelitis, though it looks like with this widely distributed areas of destruction. The discharge was. Did you do bacteriology?
No, I didn't actually do bacteriology on this charge. No, I didn't.
So,
No.
so it was not putted. It was not. Her general condition was.
She was generally okay. She was actually managing her own daily life. She was cooking. She was doing everything like ladies do. No, not
No,
not to talk about it now. But
no, it's well, I would also think of the tumor, so I would do MRI.
right, we
Also-
actually did MRI scan on this lady. I think we did the MRI scan. Let me just try to get it. محمد فتحي معانا هنا صح؟ مش معانا. Okay. I think we did the MRI scan, but it's not actually, I have not put on these slides basically. It's again a MRI scan. It was very suggestive of being inflammatory process. It's not neoplastic. There was no kind of homogeneous enhancement kind of thing. So, so then Dr. Magid Bahir, how would you manage? How would you?
Well, I have to explore. But
Sorry?
I have to explore.
To explore.
Yes, but under umbrella of antibiotics. I think this kind of inflammatory mishap.
Right.
Ah.
Okay. Any different opinions? Exploration, right? Okay. So I'll show you because again, the time limit is. So this is when I opened this E, I could see the pus coming out through this bare hole that was shown on the scan. And very strange, actually, the bone here was very flimsy. With the drill, it just comes out as if you're drilling mahallabiyya, يعني, drilling something very spongy. So, so you can even the color of the bone was almost going into being necrotic bone, basically.
Did you do the scintigraphy before the exploration?
Did I do
Scintigraphy for
cysternography?
no scintigraphy
No, I didn't do any
No.
bone scan.
to extrude the osteomyelitis.
Because for me,
Scintigraphy
it
is
was
very
like,
helpful.
I was thinking actually, there is something to do with this tapedotomy. That was my thinking.
No, I mean the scintigraphy,
Yeah,
bone scintigraphy.
which is technetium 99, gallium 67. Is that what you mean? Yeah. But no, we have not done. No. So basically, and you could see that this is actually a defect in the mastoid tip going down to the neck. By the way, there was kind of Bizel's abscess in this lady. And the bone is almost dead, is almost necrotic bone, essentially. And pussy. It's a necrotic, pussy, unhealthy bone. So much so that it was easy to go into the neck to the insertion of the sternocleidomastoid muscle and advancing it to partially obliterate this cavity.
This is osteomyelitis.
Yes.
There is pus, microabscesses.
I'll tell you osteomyelitis of a special sort, not actually the classical skull-based
Yes,
osteomyelitis
of course,
that
of course.
we classified it into lateral and central,
course,
that kind of thing.
course, of course.
So yes, it's a kind of a special type of osteomyelitis. So what I did was actually I advanced the sternocleidomastoid muscle to partially obliterate the cavity, but then I think what is more relevant, obviously I ended up doing canal wall down mastectomy and partial obliteration of the cavity. And again, that is 2 weeks post-operatively for this lady. This is the cavity with this yellowish tinge in it, which kind of probably some air cells harboring some sort of cholesterogranuloma. And that was 2 weeks. Now, 2 months post-operatively, you could see now the cavity is really looking pristine. There was no discharge, no infection. Everything was fine. So obviously, I sent this for histopathology. And the result came back, wow. Any clue as to what the diagnosis was? Was Kalbis osteomyelitis, yeah? Okay, right. So that was the histopathology of this lady, and that was the report coming as highly suggestive of reparative granuloma, which is to do somehow with the, with the stapedotomy. So the patient until today, I'm actually following this patient now almost for 4 or 5 years with nauseous. And I should thank you very much for your time. Thank you.